Hi, everybody. My name is Shaan Sareen, and the title of my research project is The Impact of Early Childhood Caries on Oral Health-Related Quality of Life. So, as mentioned in the previous presentation by Mohammed, early childhood caries is defined as dental decay involving the primary teeth of children less than 6 years old or 72 months old. And as often the case, particularly with severe cases of ECC, a dental surgery is needed for treatment, and the prevalence for dental surgery as a treatment for ECC in Manitoba is about 27 for every 1,000 children. And in northern regions of Manitoba, it's significantly higher at about 116 for every 1,000 children. The problem with the surgical approach is that it fails to address many of the developmental factors associated with ECC. So many children often develop new or recurrent caries only months after the dental surgery. One of the many risk factors associated with ECC is oral health related quality of life. So my job for the summer was to analyze a CHR study, which was a case controlled study involving 467 children in Manitoba, 283 of which had early childhood caries and 184 were caries free. Parents were asked to fill out a questionnaire regarding their child's oral health, and the associated oral microbiome data for the children was also collected as part of the study. So my objective for my research project was to analyze the CHR questionnaire to determine associations between oral health-related quality of life, ECC, and sex of the child. We then further analyzed 4 additional covariates, which were age in months, insurance coverage of the child for dental purposes, and whether the child was living in an urban or rural setting, as well as the child's nutrition risk. We were able to evaluate nutrition risk through a nutrition screening tool called NutriStep, which is a valid and reliable way of evaluating nutrition risk, particularly in preschool children. We were able to measure oral health related quality of life using the Early Childhood Oral Health Impact Scale, or commonly short for ECOIS. And similar to NutriStep, it is a valid and reliable method, particularly when evaluating oral health related quality of life in preschool children. So as I said, ECOIS is well validated in the literature and is very well used across the world. As you can see on the slide, it is translated in many different languages and used in many different languages. There's also been studies looking at specifically the cultural adaptation, because oftentimes when we have a questionnaire like this, sometimes differences in culture can lead to difference in the outcome variable for the ECOIS questionnaire. So it's been well validated in Peruvian children, Chilean children, Turkish children, and also Mexican children. And according to a recent study done by Chai and colleagues, they evaluated a total of about 12 tools to evaluate oral health related quality of life. And they found that no questionnaire was a one size fits all, and one was the best for measuring everything. Instead, each questionnaire had a very specific purpose, and ECOIS is specific to preschool children and their families, or I guess measuring the oral health related quality of life in preschool children and their families, and is also shown a good ability in distinguishing between those with early childhood caries and those that are caries free. So moving into how the ECOIS questionnaire is broken down. So it is subdivided into 2 sections, the child impact section and the family impact section. And each section is then further subdivided into different domains. So the child symptom domain is a question asking if the child has experienced any oral or dental pain and how often they experience it. And the other questions are scored in a similar way. And the child function domain asks if the child has been affected in their day-to-day life as a result of their oral health. And then the psychological and self-image domain gets into whether the child has been affected in various psychological or self-confidence ways as a result of their oral health. The family impact section focuses on if the parents have felt guilty or upset as a result of their child's oral health, and the family function domain focuses on if primarily if the family has been financially impacted in any way. So responses for each question were graded on a scale of 0 to 4, and there were 13 questions. So the theoretical minimum was 0, and the theoretical maximum for the total ECOA score was 52. It's important to note, particularly with this questionnaire, that ECOAS is measuring oral health impact. So a higher ECOA score indicates lower oral health related quality of life. So moving into the first set of results, as you can see, the difference between the Caries free group and the Caries group was statistically significant using the p-test, or the t-test, sorry. It was significant both in the child impact section as well as the family impact section, and also for the total ECOA score. When we evaluated the differences between sex, both within the ECC group and also the Caries group, it was found that these differences were not statistically significant. Moving on to the right side of the screen, we get a sense of the different distributions, particularly for the total ECOA score. So for the Caries free group, the majority of the responses were very close to 0, if not slightly above. But for the ECC group, the mean is significantly higher, and there's also a greater distribution for oral health impact. So many scores are getting into the 30s and even close to the 40s range. It's also important to note that the ECOA scores that we found in our study align with previous ECOA scores that we found in our lab. So ECOA scores of those requiring surgery in Manitoba, we found to be about 7, and the ECOA scores for First Nations communities, particularly those with ECC, was about 6, and those that were Caries free was about 2. So very similar to the scores that we received in the study that we had just performed. So moving on into more sets of results. As previously stated in the other slide, the association between Caries status and ECOA score was significant. We evaluated this using the linear regression as well as the multiple regression, and that allowed us to control for other variables in the study. So we found that ECC was associated with higher ECOA scores and therefore lower oral health related quality of life. We were able to verify that sex was not associated with oral health related quality of life. When we evaluated age and insurance coverage, we found that they were significant using the linear regression. However, when we were able to control for other variables using the multiple regression, both age and insurance coverage were not associated with oral health related quality of life. Taking a look at the child's residency, we found that children living in rural settings were associated with higher ECOA scores and lower oral health related quality of life. And we also found that those with higher nutrition risk were also associated with lower quality of life. So the take-home message from the findings of our study was that ECC, rural living, and high nutrition risk were all associated with lower oral health related quality of life, whilst child age, sex, and whether the child had dental insurance coverage were not associated with oral health related quality of life. So some limitations to the study were the fact that we used a convenience sample of about 467. As Mohammed mentioned in the previous presentation, we gathered these samples from our clinics such as CRIM and Access Downtown, as well as Mount Carmel Clinic. We used a cross-sectional design, so unfortunately we weren't able to see the ECOA scores over a longer period of time. And there's also possible reporting biases on part of the parents. So there could be a level of human error associated with recall and also reporting bias associated with the questionnaire. Some future steps for this project include investigating these associations with the oral microbiome data that was also collected as part of the study, as well as connecting these findings with taste genetics, and particularly certain taste receptors with associations between ECC and oral health related quality of life. I'd like to thank everybody for listening to my presentation and everybody who's helped me out throughout the summer with my research project. And if there's any questions, I'm more than willing to help answer them. Thank you.